Assalamu alaikum. We are back again with our fifth lecture on rheumatology and bone disease. We move further forward in investigations of rheumatology or rheumatological diseases. So we will start with the blood test, hematology. So abnormalities in the full blood count often occur in inflammatory rheumatic diseases, but changes are usually non-specific. Examples include neutrophilia. Neutrophilia means increased neutrophil count. So neutrophilia or increased count of neutrophil is seen in crystal arthritis. Crystal arthritis means gout, pseudogout, etc. and septic arthritis. So neutrophilia is found in two types of inflammatory conditions of the joint. They are septic arthritis and crystal arthritis. And neutropenia, that means reduced number of neutrophil. Neutropenia is seen in SLE, systemic lupus erythematosus. Okay, neutropenia is found in SLE. Neutrophilia is seen in septic arthritis and crystal arthritis. Lymphopenia, that means, penia means reduced number. So lymphopenia means reduced number of lymphocytes. So lymphopenia is seen in autoimmune rheumatic disease and connective tissue diseases. Okay, so here important was neutrophilia found in septic arthritis and crystal arthritis, and neutropenia found in SLE. Okay. Then reduced levels of hemoglobin and raised platelets are a common and important finding in active inflammatory disease. So in active inflammatory diseases, hemoglobin is reduced. So you will find anemia, and that will be normocytic normochromic anemia typically, and raised platelets. Raised platelets. So in active inflammatory diseases, hemoglobin is reduced and platelet count is increased. Okay, or there is thrombocytosis. Increased platelet count is called thrombocytosis. Some disease modifying anti-rheumatic drugs, they are typically called DMARDs, the abbreviated forms, DMARD, and biologics can cause marrow toxicity. Marrow toxicity means toxic to the bone marrow. So bone marrow is the site from where all blood cells are synthesized. So in bone marrow toxicity, there will be reduced count of all kind of blood cells and require regular monitoring of the full blood count. So patients who receive DMARDs like methotrexate, sulfasalazine, etc., and biologics, there will be several biologics. We will know their names eventually. So these kind of drugs cause bone marrow toxicity, and the count of different blood cells is reduced. So we will have to monitor that with the full blood count or complete blood count, CBC. So we will continue with the biochemistry. Okay. So here, serum levels of uric acid are usually raised in gout. Okay. So we all know that. At least most of us know this. Serum levels of uric acid, that means increased uric acid level in the blood, hyperuricemia. So it usually occurs in gout. But we have to remember that a normal level of uric acid does not exclude gout. So if someone has acute monoarthritis, and we advise him serum uric acid and the results come normal, we cannot say that he doesn't have gout. Okay, it is not a universal feature. It is typically raised in gout, but not a universal feature in gout. Okay, so especially during an acute attack of gout, when uric acid levels temporarily fall. So Davidson says that in acute attack of gout, the uric acid level in the blood paradoxically falls temporarily. Then it slowly rises. So in acute attack of gout, the uric acid level will be rather low. Equally, an elevated serum uric acid does not confirm the diagnosis of gout. So here is another aspect. Anyone whose uric acid level is increased doesn't mean that he is suffering from gout. Okay, since most hyperuricemic people never develop gout. So most of the patients who have hyperuricemia never develop gout. So this is an important line. So Then levels of C-reactive protein or CRP are a useful marker of infection and inflammation. We all know that, and are more specific than the ESR. So erythrocyte sedimentation rate or ESR and C-reactive protein CRP, they are both markers of inflammation, infection, but ESR is rather non-specific and CRP is more specific than ESR. Okay. So here SLE and systemic sclerosis, here CRP may be normal, but the ESR is raised in active disease. So in active SLE, in active systemic sclerosis, ESR is raised, but CRP remains normal. We will have to memorize this. So in SLE and in systemic sclerosis, only ESR level is raised, but CRP level is normal. So when you appear in the exams, there is an important exam question. It says that in which of the following conditions ESR is raised but normal CRP? Okay. So here are two conditions we find, SLE and systemic sclerosis. Okay. Accordingly, an elevated CRP in a patient with SLE or systemic sclerosis suggests an intercurrent illness such as sepsis rather than the active disease. So we just learned that in active SLE and active systemic sclerosis, ESR is raised but CRP is normal. But if in these patients of SLE and active systemic sclerosis, we find that the CRP is also raised, it indicates that it is not due to the active disease. It is rather due to an infection, intercurrent illness, such as sepsis. Okay. Next. Here is an important immunological test, rheumatoid factor or RF. RF. So rheumatoid factor or RF, it is an antibody directed against the Fc fragment of human immunoglobulin. Okay. So it is an antibody. Which kind of antibody? IgM. IgM. It is an IgM antibody. Against what? Antibodies are generally produced in our body against antigens. So this rheumatoid factor, which is an IgM type of antibody, this is produced against what antigen? This is produced against Fc portion of the IgG. So another, it is an antibody which is produced against another immunoglobulin, IgG. Which portion? Not whole IgG, the Fc portion. Okay, the Fc portion of the IgG. Okay, so it is important, very important. It has appeared several times in different exams around the world. Single best answer type of question. So this is very important. We have to remember this. Rheumatoid factor is an antibody, rather IgM type of antibody, which is produced against the Fc portion of immunoglobulin IgG. Okay. Next. So we will have to go through this box. So which conditions are associated with positive rheumatoid factor? So first we will have to see that in which conditions rheumatoid factor is 100% positive, every time positive. Okay. So rheumatoid arthritis with rheumatoid nodules and extra-articular manifestations. In this scenario, RA factor or rheumatoid factor will always be positive in 100% times. Okay. So we will have to remember that not just rheumatoid arthritis, not every case of rheumatoid arthritis. In rheumatoid arthritis with rheumatoid nodules with extra-articular manifestations, if all these features are present, then in every such case, rheumatoid factor will be positive. And next, in overall all rheumatoid arthritis cases, rheumatoid factor is found positive in only 70% of cases. So the rest of the 30% cases, their rheumatoid factor will be found false negative. Okay, false negative. Then primary Sjogren syndrome. Primary Sjogren syndrome. In these patients, we will also find rheumatoid factor positive in most of the cases, 90% cases. Primary Sjogren syndrome and mixed essential cryoglobulinemia, another condition where RA factor is most of the time, 90% of the cases, positive. Another interesting feature, in all people who are more than 65 years old, they may be healthy people. In 20% of those persons, rheumatoid factor is found positive. So 65 plus age, 20% cases, rheumatoid factor is found positive, though they have no disease. Okay, we'll have to remember that. Okay, next we move on. Another antibody, which is usually seen in rheumatoid arthritis patients, anti-citrullinated peptide antibody. So first, you remember that this is an antibody, anti-citrullinated peptide antibody. This is in abbreviated form, it is called SCPA, or in some countries, we advise it as anti-CCP. So what does it mean? What do you mean by anti-CCP? Anti-cyclic citrullinated peptide. Anti-cyclic citrullinated peptide. So anti-CCP and SCPA both are same. Both are same terms. So anti-CCP and SCPA both are same terms. So this antibody, SCPA, anti-citrullinated peptide antibody, this antibody is highly specific for rheumatoid arthritis in more than 95%. Its specificity is more than 95%. So very important. Okay, its specificity is more than 95%. So SCPA, it is an antibody. It is a peptide type of antibody in which the amino acid arginine has been converted to citrulline. So arginine is an amino acid. It is converted to another amino acid, citrulline, by peptidyl arginine deaminase enzyme. Okay. And this enzyme, peptidyl arginine deaminase, this enzyme is abundant in inflamed synovium. So in synovial cavity, which is inflamed, in that inflamed synovial cavity, there is abundance of this enzyme, peptidyl arginine deaminase. Okay. This enzyme converts one amino acid, arginine, to citrulline. Okay. And if this amino acid is converted to citrulline, then against that citrulline, an antibody is produced, which is SCPA, anti-citrullinated peptide antibody. As it is being produced against citrulline, this is called anti-citrulline. Okay. So SCPA has largely superseded rheumatoid factor in the diagnosis of rheumatoid arthritis. So rheumatoid factor is rather a screening investigation, we can say. And SCPA is rather a confirmatory investigation for rheumatoid arthritis. This is not that much simple, but I am telling you because just to remember this, that it has more significance than rheumatoid factor. Okay. Then we come to another antibody, anti-nuclear antibody, ANA. We typically know this ANA. So anti-nuclear antibodies, another type of antibodies, against what? Directed against one or more component of the cell nucleus. So one or more components of the cell nucleus act as the antigenic stimuli here for these antibodies, anti-nuclear antibody. The name suggests the thing itself. ANAs are not associated with disease severity or disease activity. Okay, they are not associated with disease activity or disease severity. The most common indication for ANA testing is in patients suspected of having SLE. So it's very important. If we suspect any patient of having SLE, we must advise this test, ANA. Not only SLE or other autoimmune connective tissue diseases, they can also be diagnosed with ANA. ANA has high sensitivity for SLE. So the sensitivity is 100%. ANA is 100% sensitive for SLE. Okay. But its specificity is low. Okay. And then a negative ANA virtually excludes SLE. So because ANA is 100% sensitive for SLE, so if ANA comes negative in any patient, so we may say that this patient does not have SLE. So, okay, this patient does not have SLE. The same we cannot tell about the rheumatoid arthritis, because overall in rheumatoid arthritis, the sensitivity of rheumatoid factor is 70%. So in every 30 patients who are suffering, in every 100 patients who are suffering from rheumatoid arthritis, 30 of them will test negative for rheumatoid factor. Okay. So if rheumatoid factor comes negative in a patient with rheumatoid arthritis, we cannot say that he does not have rheumatoid arthritis. That means we cannot exclude rheumatoid arthritis, but that is not same for ANA. If any suspected SLE patient tests negative for ANA, if the lab is good and reliable, we can say that this patient does not have SLE. Okay. So, but a positive ANA result does not confirm SLE. We will have to remember that. Okay. If ANA is positive, we can suspect SLE, but SLE is not confirmed if ANA is positive. Okay. So, confirmatory investigation will be another thing. We do some different tests like anti-DS DNA, anti-Smith antibody. We will talk about that later. So, we know about ANA now. Okay. So these lines are very important for SBA type questions. They frequently come in your MRCP exams, your FCPS exams. Okay. So let's go back. We skipped 2 tables earlier here. So these topics are not relevant yet. We will come back to those boxes later. Okay. Now we see another box, 26.8, conditions associated with a positive ANA, positive anti-nuclear antibody. So you see, in SLE, the sensitivity is 100%. So there are some other diseases which are 100% sensitive for ANA. Okay, mixed connective tissue disease and autoimmune hepatitis. So these 3 diseases test 100% positive for ANA. Okay, SLE, mixed connective tissue disease, and autoimmune hepatitis. Yeah, you will have to memorize this: SLE, autoimmune hepatitis, and mixed connective tissue disease. Okay. And in systemic sclerosis also, in 90 to 95% cases, they test positive for ANA. Okay. So other diseases, we can just read down the names, but you will have to remember or memorize these names. Okay. 100% positive in which cases. Okay. Let's move on. So anti-DNA antibodies bind to double-stranded DNA. Okay. So DNAs are typically double-stranded. So against this double-stranded DNA, there are some antibodies that are formed. Those are called anti-DS DNA. Let me write down anti-DS DNA. So anti-double-stranded DNA. This is another type of antibody. They are useful in SLE monitoring as high titers are associated with more severe disease. Okay. Anti-DS DNA is an antibody which is, if found positive, useful in monitoring the disease activity of SLE. Okay. So if anti-DS DNA level is raised, so SLE is also increased severity. And an increase in antibody titer may precede relapse. So if an SLE patient who was previously controlled with medications, if we find that anti-DS DNA is suddenly increased, we will suspect that he has a relapse. Okay. Next antibody, antiphospholipid antibody. Okay, antiphospholipid antibody. So these antibodies can be detected in patients with SLE and in the antiphospholipid syndrome. So antiphospholipid antibodies are found mainly in antiphospholipid syndrome. Okay. And also they are found positive in SLE. In clinical practice, the most commonly used tests are for antibodies to cardiolipin or anti-beta-2 glycoprotein 1 and the dilute Russell-Viper venom test. So antiphospholipid antibody test, there are several types. They are anti-cardiolipin antibody. This is anti-beta-2 glycoprotein 1 antibody and dilute Russell-Viper venom test. 3 types of antiphospholipid antibody test. So let me say it again. Anti-cardiolipin antibody test, anti-beta-2 glycoprotein 1 test, and also dilute Russell-Viper venom test. Okay. Next, another antibody, anti-neutrophil cytoplasmic antibody, or abbreviated form is ANCA. Anti-neutrophil cytoplasmic antibody, or ANCA. So these are IgG antibodies directed against the cytoplasmic constituents of neutrophil. Okay. So first, Try to memorize this portion of this line. Okay. ANCA, their name suggests their identity, anti-neutrophil cytoplasmic antibody. So these are some antibodies. Antibodies against which antigen? The antigens in cytoplasm of neutrophils. Neutrophils are one kind of WBC, white blood cell. In their cytoplasm, there are some antigens, and ANCA are some antibodies that are produced against those antigens. Okay. So ANCA are useful in the diagnosis and monitoring of systemic vasculitis, not localized. Try to remember. So ANCA are useful in both diagnosis and prognosis of systemic vasculitis. Okay, very important. This is an important information for SBA. Okay. Then two common patterns of anti-neutrophil cytoplasmic antibody are found. They are C-ANCA and P-ANCA. C-ANCA means cytoplasmic, okay, and P-ANCA means perinuclear, okay. So cytoplasmic ANCA, here antibodies are produced against proteinase 3, a cytoplasmic enzyme. Proteinase 3 is an enzyme which remains in the cytoplasm of neutrophil. So antibody to proteinase 3 is one type of C-ANCA, cytoplasmic ANCA. And perinuclear. Perinuclear means around the nucleus. The antigens remain in the cytoplasm, but around the nucleus, perinuclear. So here, antibodies to myeloperoxidase and other proteins such as lactoferrin, elastase. So myeloperoxidase, lactoferrin, elastase, these substances remain around the nucleus of neutrophils. Okay. So antibodies produced against them are called P-ANCA, perinuclear anti-neutrophil cytoplasmic antibody, P-ANCA. So C-ANCA was antibody to proteinase 3, anti-proteinase 3. And P-ANCA examples are anti-myeloperoxidase, anti-lactoferrin, and anti-elastase. Anti-myeloperoxidase, anti-lactoferrin, anti-elastase. So C-ANCA was anti-proteinase 3, and P-ANCA are anti-myeloperoxidase, anti-lactoferrin, and anti-elastase. Okay, these antibodies are not specific for vasculitis. Okay, ANCA antibodies, they are not specific for vasculitis. Okay, they are found in systemic vasculitis, but not specific for vasculitis. There are some other conditions where we will find these ANCA antibodies. And positive results may be found in autoimmune liver disease. So autoimmune liver disease, here we may also find the ANCA positive. Also in malignancy, ANCA may be positive. Also in infection like bacterial and HIV virus infections, the ANCA may be positive. In IBD, inflammatory bowel disease, in rheumatoid arthritis, in SLE, and pulmonary fibrosis, these conditions here, ANCA may also be positive. So ANCA is not a 100% specific test for systemic vasculitis. There are some other conditions where ANCA may be found positive, but ANCA is typically found raised in systemic vasculitis. So we will have to remember this. Okay. Next, complement and complement component antibodies. So low complement C3 is an indicator of active SLE. Very important information here. So in active SLE, the complement level C3 will be low. Okay. Complement level C3 will be low in active SLE. Okay. And some forms of vasculitis owing to consumption of complement by immune complexes. Okay. Okay. We'll skip those lines. Okay. So we have studied about some cytoplasmic antibodies. Okay. Means antibodies against some cytoplasmic components. Now we will find some antibodies against nuclear antigens. Extractable nuclear antigens. Antibodies against extractable nuclear antigens. Okay. Which are they? They are anti-centromere antibody. Okay. Anti-centromere antibody. Anti-centromere antibody found positive in localized cutaneous systemic sclerosis. This is a variety of systemic sclerosis, localized cutaneous systemic sclerosis. Anti-centromere antibody is found positive in localized cutaneous systemic sclerosis. Anti-centromere antibody is found positive in localized cutaneous systemic sclerosis. Anti-histone antibody, very, very, very much important Antihistone antibody is found positive in mostly drug-induced lupus. Drug-induced lupus. That means SLE caused by side effect of drug. Okay. So antihistone antibody is a type of anti-nuclear antibody which is found positive in drug-induced lupus. Okay. Then anti-Jo1 antibody. Anti-Jo1, its another name is antihistidyl tRNA synthetase. Okay. Anti-Jo1 or antihistidyl transfer RNA synthetase. Anti-Jo1 or antihistidyl transfer RNA synthetase. Anti-Jo1 is found positive in polymyositis and dermatomyositis. Both are myositis. So Jo1 will be found positive in myositis, dermatomyositis, and polymyositis. Okay. Then we will see two antibodies. One is anti-Rho, RO-Rho, and another is anti-La, LA-La. The other name of anti-Rho is SSA, anti-SSA antibody, and another name of anti-La is anti-SSB. So which one is A, which one is B? We'll have to remember that. So because Rho is A, that is why I named it earlier than the La. Okay, Rho La. We'll find the sequence Rho La. Okay, let me write it down here. Rho La. Okay, remember this. Rho is A, anti-SSA, and La is B, anti-SSB. Next, let's come to anti-SSA or anti-Rho. It is found positive in SLE. Maternal anti-Rho antibodies are associated with neonatal lupus and congenital heart block. Very important. So anti-Rho associated with neonatal lupus, congenital heart block, and also Sjogren syndrome. Neonatal lupus, congenital heart block, and Sjogren syndrome. Anti-Rho, SLE, also neonatal lupus, congenital heart block, and Sjogren syndrome. Then anti-La. Anti-La here found in SLE and Sjogren syndrome. So anti-La is also found in. So there are some common diseases where both anti-Rho and anti-La positive. They are SLE and Sjogren syndrome. Okay, but in neonatal lupus and in congenital heart block, only anti-Rho or anti-SSA are positive. Okay, so another one is anti-ribonucleoprotein or anti-RNP. This is 100% positive in mixed connective tissue disease. Very, very, very important line. Okay. In mixed connective tissue disease, anti-RNP is found 100% positive. Okay. Anti-RNP is also found 100% positive. Okay. In mixed connective tissue disease, anti-RNP is found 100% positive. Mixed connective tissue disease. Okay. Anti-RNP. Next one is anti-RNA polymerase. This is found positive in diffuse systemic sclerosis. Anti-RNA polymerase is found positive in diffuse systemic sclerosis. In diffuse systemic sclerosis, another antibody is positive, which is anti-SCL70 or anti-topoisomerase 1. We'll have to remember the alternative names also. Okay, this frequently appear in the exams. Anti-SCL70 or anti-topoisomerase 1 antibody found positive in diffuse systemic sclerosis. Anti-RNA polymerase also found positive in diffuse systemic sclerosis. So in diffuse systemic sclerosis, two types of antibody are increased. They are anti-RNA polymerase and anti-SCL70 or anti-topoisomerase 1. Okay. Another condition we studied earlier where localized cutaneous systemic sclerosis. The antibody associated is anti-centromere antibody. So I gave a lot of time in this box. We'll have to memorize this box. We must memorize this box. This is very, very, very much important. So we'll learn about tissue biopsy. We skipped two boxes in the earlier page. We will learn about them in the next class. So this lecture ends here. We will come back with the sixth lecture very soon, inshallah. Till then, I hope you will try to memorize these informations that I delivered to you according to the textbook. Okay, I did not go beyond the textbook at all, because whenever we try to practice independently, if we use the reference of textbooks, those that are books that are internationally acknowledged, so we can be smart doctors. Okay, so till then, bye for now. আল্লাহ হাফেজ। সালাম আলাইকুম।